welcome to today's session called Looking Beyond the Label, the Treatment-Resistant Client. And the faculty presenter is Dr. Milan Khara. Okay, so if you are interested in receiving a letter of completion for today's session, you must have completed the registration and pre-learning assessment. You must sign in to view the live webinar session using your first and last name. But if you've participated as a group, not to worry, just email me. My contact information is at the side here by 2 p.m. today with a list of the group. Everyone's name in the group. And then following today's session, you must complete the evaluation and post-learning assessment. Okay, these webinars are being live tweeted. Follow at PS Quit Smoking on Twitter and use the hashtag #TeachWebinar. Dr. Milan Khara is a UK-trained physician employed by Vancouver Coastal Health Addiction Services. He joined this organization in 2003, having previously worked as an addiction medicine consultant at CAMH in Toronto. And I'll let you all read the rest of the bio yourselves. Okay, our disclosures, Dr. Khara's disclosures. Teach curriculum and slides were developed and compiled with funding from the Government of Ontario, Ministry of Health and Long-Term Care. Content of slides are based on the following 3 guidelines. These materials, as well as the verbal presentations and ended discussions, set out only general principles and approaches and do not replace the need for individualized clinical assessment and treatment. Okay, now I'm just going to do a couple of polling questions here. So the first question is asking the type of organization that you work for. So I'm just going to bring it up here. Okay, great. It looks like there's almost an even split between hospitals and public health units. Okay, so the next question is asking for your discipline. Here we are. Now there's a lot of selection there, so be sure to scroll down. Okay, looks like the majority of you are registered nurses, followed closely by health promoters and educators. Great, and the last question just asks what region you serve. Okay, most of you from the Northeast area. So I'm going to hand it over now to Dr. Khara. I apologize for the echo on my end, so I'll hand it off now.
Okay, great. So I think I should be echo-free. And again, apologies for the technical difficulties. It was actually working beautifully at 8:30 this morning, but such is life. So first of all, good morning to those of you on this coast. Of course, most of you I think are in Ontario, and good afternoon to you all, and thank you for attending the webinar. We've left the title slide, but the title slide I think was looking beyond the label, treatment for the resistant client, or something very similar. And the title is really chosen to give you a sense of the kind of clinical work that we do at the Vancouver General Hospital Smoking Cessation Clinic, where we see tobacco users who show up either having been referred from specialist services. So we see a number of people from cardiology who have got coronary artery disease and use tobacco and would like help in smoking cessation. We see people from respirology and other specialty departments. We see people from general practitioners. We see self referrals, and very occasionally we see staff who have come along who are still using tobacco who would like help. And when we see patients in those settings, it's reasonably common that those patients do not respond to the standard approach with NRT, for example, or with any other treatment modality. And we end up getting into titrating or combining or doing a whole variety of things with cessation medications, which would be occasionally to be considered to be outside of the label, or certainly would be considered to be not standard. And that's really what this presentation is actually going to be about today. You can see from the objectives that the learning objectives that the number one, you will hopefully understand the rationale and the logic for using medications in this manner in those who don't respond or partially respond to standard approaches. I'll then run through some specific approaches that we actually use, 5 or 6 of them, and expand on why and how. And lastly, and most importantly, I think, is to look at the evidence that supports the efficacy for these kinds of approaches and the safety, of course. It's clearly not really okay for us to be doing wild and wonderful things with medications outside of evidence. And the things we do need to be rational and need to be ideally supported by evidence, and clearly need to be safe. So I'll show you some of the evidence that hopefully underpins the practice that we have here at Vancouver General. Now, the last thing is, I'm actually quite happy if people want to type into the chat box in real time. That will keep everyone awake, which is a good thing, I think. And so if you do have something that is really pressing, something that you think I've skipped over or not explained very well, then put it into the chat box. I can keep an eye on that, and we can maybe answer questions as we go along. We will have time at the end as well for some discussion. So please do that if you feel comfortable doing so. Okay, so that's essentially what we're going to talk about. You saw my disclosure slide. We ran over it rather quickly as we're trying to catch up or make up for lost time. But I have a number of disclosures to make. I work primarily for Vancouver Coastal Health, but I've worked with other organisations in the last 12 months. Not the tobacco industry, but I have worked with the makers of smoking cessation medications. And the way that I'm going to hopefully mitigate any perception of bias or any potential bias is, first of all, I'm talking about all smoking cessation medications. I will not be promoting one or other, and hopefully you will agree that what I present is fair and unbiased. Everything that I present is from peer-reviewed, published research. And last but not least, if there is any sense that something presented is not fair or is skewed or makes anybody uncomfortable, then you're very welcome to either type in the chat box or send me an email, or whichever way you wish to raise that point. I'd be happy to discuss it. Okay. So this is a very important disclosure, actually, or a very important thing to underline. And this is from the American Tobacco Treatment Guideline, a little out of date now, from 2008. We have a very similar guideline in this country from the folks at CAMH, from Canadapt. And these guidelines essentially say the same thing, and that is that those people who are interested in quitting smoking should be treated with the 2 evidence-based treatment modalities. And the 2 evidence-based treatment modalities are counseling and medications. Now, I'm going to be talking about medications in this presentation. That is not for one moment to suggest that the provision of appropriately intensive counseling is not important in those who we see as resistant to treatment or who we see as partial responders. The process of ongoing assessment to understand what the obstacles to success are clearly an inherent part of tobacco treatment. And it may be that loading up on medications is entirely inappropriate if actually what we're dealing with is a degree of ambivalence. Clearly, in that situation, we would do some more motivational interviewing. We would examine the lack of readiness to make change. We would do the kind of counselling work that I think we're all familiar with as being a crucial part of our cessation practice. So again, just to really underline that this presentation should not be seen as advocating for the use of medications in an aggressive way, whilst forgetting about doing the equally important counselling work that really is, I think we all understand, an ingredient for success with these patients. So that's an important point to make. Okay. All right. So now off-label is a term that we hear bandied around a lot, I think, in cessation practice. And I thought it would be good to just for one moment step back from that term and actually define it so that we're all using the term to mean the same thing. Off-label quite literally means using medications that are outside of the exact wording on the product insert. And what we mean by that is we're prescribing medications for indications or using dosages or dosage forms that have not been approved. Now, just to perk up your ears, I'll give you another example of where we use medications in an off-label manner. Premature ejaculation is a condition that is treated often with behavioral techniques, but it's not uncommonly treated with medications, and it's most commonly treated with SSRIs, in fact with Paxil specifically. And it's interesting that though we use Paxil for the treatment of this condition, there is actually no approved indication for the use of Paxil for this condition. It's used entirely off-label. And the history of the use of that medication in the treatment of premature ejaculation is that when these medications, the SSRIs, came along in the late 80s and early 90s and started to become the treatment of choice for anxiety and depression, it was noted that the sexual side effects actually for some patients were actually quite troublesome. And one of those sexual side effects was delayed ejaculation, or in fact anorgasmia. And so not unreasonably, it was thought that this might be a product that is worth using in the context of those who have the problem of premature ejaculation. And that's how this medication has come to be used in an off-label manner for this particular condition. So off-label can be not only using medications at dosages that are unapproved, but also for indications that have not been yet added to the label. The other thing about using medications off-label, of course, is that we need to use medications with some sound scientific rationale. We can't simply make this stuff up as we go along. So when we add a second patch, for example, the scientific rationale is that if one patch seems to work a little bit, well, then two patches might work a little bit better. And ideally, when we take these approaches, we do them in the context of some medical evidence. And we should be maintaining records of the product's use and effects. And this is important information, not least because we do make ourselves somewhat vulnerable to medical legal action when we start to stray off the label. If I have 4 patches on somebody and they have a myocardial infarction and they decide that their myocardial infarction was caused by their 4 patches, and in almost all certainty it's not caused by the 4 patches but by the 3 decades of smoking that has preceded the use of 3 or 4 patches, but we may be asked to defend ourselves and to defend our practice. And the way that we do that in front of a court potentially is by pointing to a body of evidence that suggests that what we did was safe and in fact had demonstrated some efficacy at some time in the past. So that's what we mean by off-label treatment, and some of what I present is actually about off-label use of medications. Not all of what I present, but some of what I present. Okay, so what are some of the common examples in smoking cessation practice? Certainly, as I said, we can increase doses. We can go up to more than 1 patch. We can also apply that to the use of varenicline. We can go above standard doses of varenicline. to considerably higher doses actually. And these are the kinds of things we do with those who respond partly to treatment in our specialist cessation setting. NRT combinations, certainly a very common practice today, and in fact actually no longer off-label in this country since January of 2016. But for many years, adding the patch and gum together was considered off-label or outside of the wording on the label. The third bullet you see there is the use of NRT whilst smoking continues, so NRT with concurrent smoking. And this, of course, is what we do when we are taking these reduce to quit approaches, these approaches where there is cigarette fading or slow cigarette reduction whilst there is the use of NRT. Again, these kinds of approaches were outside of the label until relatively recently, as labels have started to change. And the fourth bullet you see there is the use of varenicline with concurrent smoking. So, as most of you will know, when we use varenicline, the patient is supposed to quit in the second week. But the labels again have started to change to allow more flexible use of varenicline and this so-called reduce to quit treatment paradigm. We can combine NRT and varenicline even though we're not supposed to. It's a reasonably rational thing to do, as I'll explain in some more detail later on. And we also have combinations involving bupropion as well, which have been shown to have some increased efficacy. So I'll talk about all of those specifically as we move through this presentation. And last but not least, and I had a kind of a heart-sink moment as I was creating this presentation, thinking about whether I should actually include the use of electronic cigarettes for those who we might consider to be treatment resistant or partial responders to our more orthodox approaches. And in the end, I decided that maybe I should, because inevitably I'll be asked the question. But I'm sure everybody listening has been asked by a patient at one time or another, can I use the electronic cigarette to help me to quit? Or I'm already using the electronic cigarette to help me to quit. And I think we need to have a position based on the evidence as it stands today. There is clearly no consensus, but I think we have to have a position that is defensible, and I'll certainly stake out my position a little later on in the presentation. So I'm going to deal with all of these issues one by one. Okay, stepping back for a second, just to remind ourselves what we're actually doing when we use medications. We all know that tobacco use disorder is a bona fide addictive disorder. I think most of you will understand that what we're actually treating is an alteration in the midbrain. And the primary alteration is that the receptor that you see on the slide, the alpha-4 beta-2 nicotinic acetylcholine receptor, where nicotine from tobacco delivered from tobacco lands when there is smoking, this receptor is the target of our medications. So we know that when these receptors upregulate and the use of tobacco is interrupted, that this upregulation of receptors will lead to a nicotine withdrawal syndrome if nicotine doesn't arrive in timely fashion. And that withdrawal syndrome is primarily due to a depletion of dopamine in this part of the brain, the nucleus of accumbens, dopamine and other neurotransmitters, because of the failure to activate the nicotine receptor. And so our medications primarily focus this receptor. So clearly nicotine replacement therapy, pretty straightforward. It's the same nicotine that is in cigarettes, delivered differently of course, but we land nicotine from the patch or from the gum into this receptor, and we hopefully activate it adequately such that the depletion of dopamine in the nucleus accumbens over here is reduced, and thereby we reduce withdrawal and craving. If we use varenicline, same receptor. We now land the partial agonist, that is the varenicline molecule, into this receptor, and again we hopefully turn on the receptor enough to reduce this depletion in dopamine that occurs in the nucleus accumbens, and again reduce withdrawal and craving. With varenicline, we also get that antagonist effect where we block the receptor from nicotine if continuing smoking occurs. and that leads to a reduction in the reinforcing effects of tobacco use behavior. So this receptor is where we target our treatment. But it's also the case that most of our patients will tell us that standard dosing of nicotine replacement therapy, for example, doesn't seem to work for them. And the rationale for dosing more aggressively or for combining these medications is that if we are getting inadequate occupation of these receptors with our standard approaches to treatment, and if we therefore up our game and do use these higher doses, we will get better saturation of these receptors and thereby a greater reduction of withdrawal and craving. And that's really the fundamental premise for looking at these titration principles when we treat those who are not responding well to standard doses of medication. So I can come back to that slide if there's any sense that the mode of action of the medications that we use is not clear, but I will assume that if there are no questions, everybody listening in is clear what the rationale for these more aggressive treatment approaches is. Okay, so first and foremost, the very common practice that most of you will be very familiar with, where we see our patients who have a patch on, a 21 milligram patch, for example, but are smoking maybe 2 packs of cigarettes a day. Reasonably predictably, those individuals have a partial response to a 21 milligram patch. They may come back and say that their 2 packs a day has gone down to 1 pack a day or half a pack a day, but they're struggling to make any further progress. With those patients, it's been reasonably common to put a second patch on and sometimes to end up titrating up to 3 or even 4 patches. These are practices that have become reasonably common. These practices are often reflected in hospital protocols where we're doing withdrawal management. In some settings, quite aggressive protocols that actually recommend starting at 4 patches a day for people who smoke 4 packs a day, literally making it 1 patch per packet of cigarettes. Our practice is not quite so aggressive. We have the benefit of working in an outpatient setting where we see people on sometimes a weekly or 2 weekly basis, and we tend to titrate upwards from the standard doses. But it's not uncommon to get up to these 2 or 3 patch kind of doses. Now, does this actually make sense? What is the evidence for the efficacy of this approach? And a little disappointingly, the evidence is actually not very good. There is very little evidence that higher doses actually translate to a higher likelihood of success. And that may well be because we don't have good research looking at the right populations for these kinds of approaches. There is some evidence that those who are highly dependent respond better to this approach, but we don't have good, robust evidence across the board that higher doses translate to a higher degree of success with nicotine patch. We do have some evidence that higher doses are safe, and clearly that's an important element when we're starting to load patches onto our patients. We do need to warn our patients about the risk of nicotine toxicity, those symptoms of nausea and sweating. These kinds of symptoms are uncommon. Most of our patients will treat themselves if they start to run into trouble with too much nicotine by taking their patches off. But clearly that's a message that we need to give our patients when we are using these more aggressive approaches. So that's higher doses of patch. Now what about varenicline? So standard dose, of course, is 1 milligram BID. The target quit date is between day 8 and day 14, so in the 2nd week of treatment. We have seen not so long ago a alteration to the label that actually allowed a flexible quit date, which is between day 8 and day 35. But most recently, in the United States, actually, we have seen a reduced to quit indication reach the label, where the intention is that there's a 50% reduction in smoking in the first 4 weeks, a further 50% reduction within the second 4 weeks, and then there's a quit attempt that occurs by week 12, followed by a further 12 weeks of varenicline. This has very recently been added to the monograph in the United States. It hasn't actually occurred in this country yet. And in fact, of course, in specialist settings, the exact wording of the label is somewhat irrelevant. A much preferable approach is to individualize treatment. But whilst there is progress, whilst there is a sense that varenicline is actually helping, there really seems to be no reason to be slavishly adhering to these labels. But it is interesting that the labels are moving closer to the kind of individualized approaches that we have been taking actually for some years now. What we see reasonably commonly in our patients is we put our patients on varenicline and they get a good response, but not always a response that leads to cessation. And so we see individuals who say that, for example, they've gone from a pack a day to smoking 2 or 3 cigarettes a day. And inevitably, the question at that point is, well, what do we do next to help you to move forward? And it may well be that this is not now about inadequate receptor blockade. It may actually be that it's about the triggers, that it's about the cup of coffee that goes with the cigarette. And it may be that we need to do more counseling, that we need to do more assessment to really understand what is driving the continued tobacco use. But one of the things that we occasionally do is we consider pushing up the dose of varenicline. And we can do that, and getting up to twice the standard dose is not uncommon. But that higher dose approach tends to be limited primarily by nausea. Nausea being the most common side effect that we associate with varenicline, and the one that tends to put a ceiling on the dosing. What about the evidence? Well, there is one very nice study that was published in JAMA. You can see it referred to at the bottom. It was published last year in 2015. That actually took a group of individuals who had been put on varenicline, standard dose, and who were described as non-responders. And those individuals were sectioned off in that study and were given higher dose varenicline, up to 5 milligrams a day, in fact, and compared with the placebo group. And interestingly, the higher dose group actually did no better than the placebo group. So this higher dose approach is not at this time supported by evidence. But it might be something that we need to look at some more specifically in these highly dependent populations. So that's higher dosing of varenicline, something that we do from time to time. Combinations, I think most of us are now familiar with. As I said, no longer off-label in this country. We can combine, and in fact, we have been doing this for many years. The standard approach would be to combine the long-acting patch, which gives us a passive delivery of 24 hours of nicotine, with a pocketful of gum or lozenge or inhaler or oral spray, one of the so-called short-acting NRTs. And the reason that this is conceptually attractive, I think, is that for individuals who are using a patch, who then are in a craving situation or anticipate a craving situation, they can reach into a pocket for a piece of gum or a lozenge, get a nice bolus dose of nicotine, and hopefully move through that craving situation successfully. Now, whether this is more efficacious than monotherapy because of the bolus of nicotine, or whether it's because the use of short-acting NRT actually is doing some of the very good counseling things that we recommend by delaying and distracting from that particular craving, is very difficult to say. But the evidence does suggest now that combination NRT is about 1.5 times as effective as monotherapy. And it's considered safe. The FDA in 2013 suggesting that that was the case and recommending a change in the American label to allow nicotine to be delivered by more than one NRT option. And as I said earlier, we have this change in label in 2016 and this year also. Regarding effectiveness, if you're looking for one piece of work, one study to give you an up-to-date review of effectiveness of these different agents, this Cochrane network meta-analysis is a very good place to start. Most of us, I'm sure, on this call are familiar with the Cochrane reviews that come out of the United Kingdom, these meta-analyses that look at the efficacy of a whole variety of medical interventions. They, of course, have done many for smoking cessation agents, and this 2013 network meta-analysis actually lumped together 12 of these reviews, and their conclusion when looking at the question of efficacy was, as you see here, a combination of direct and indirect evidence suggests that varenicline is more effective than bupropion or single agent NRT, but of similar efficacy to combination NRT. And I think the evidence has reached us to that point today, that if we are being asked purely on the grounds of efficacy, which is the preferable agent of choice, I think we should be saying it is either varenicline or combination NRT, purely on the efficacy question. There may be other questions around which agent is the most appropriate, but the efficacy question, I think, is best answered that way. So as I said, the FDA in 2013 suggested that multiple NRT products could be used. They also said that NRT use whilst there's concurrent smoking is not to be considered dangerous, and that very much opens the window to this reduce to quit approach, where our patients start with NRT and then look at smoking reduction and hopefully ultimately cessation as they move forward. Moving away from the old traditional approach where we literally said, here is your first patch, please give me your cigarettes, you will never smoke again in your life. That approach was a real obstacle, I think, for many of our patients who were ambivalent or uncertain or lacking in confidence. And reduce to quit is a concept that allows those who don't feel entirely ready or confident to enter the cessation game without everything being on the line. And as they hopefully see the benefits of NRT and see the benefits of a reduction in smoking and a reduction in craving, their readiness or their preparedness to make quit attempts may well actually become apparent down the road in a way that they never would have done if we couldn't have brought them into the cessation game by using NRT in this much less threatening way. And the last thing you see, the last bullet there, is the FDA's statement that the label should change to say that we can extend treatment beyond the label recommendation of 8 or 10 or 12 weeks. And again, this is a reflection of what we've been doing in specialist settings for many years, where we individualize treatment and we base the cessation of treatment, the end of NRT or varenicline or whatever, not on the calendar, but on the patient's progress, using questions such as, well, how are you doing? How long have you been quit? Are you still craving? What happens when you go into craving situations? What happens if you forget to put your patch on for a day? These are much better questions to determine dose reduction or actually ending treatment than looking at the calendar and saying, well, it's 8 weeks, it's time to stop. And the FDA now proposing that for the label in the United States, and the labels have changed to reflect that. And you actually see the yellow label change there that was applied to NRT products. Some more evidence. If we look at reduce to quit NRT, this is a nice systematic review from a few years ago that actually looked at smokers who were identified as unwilling or unable to make an abrupt quit attempt. So that very population that I described a few moments ago, these patients who do not make quit attempts because we don't consider them to be ready, well, what about just putting a patch on them? And in this study, that's exactly what we did. So we took this population of those who were unwilling or unable, and when we looked at sustained abstinence at 12 months, you can see that those who used NRT patch were twice as likely to be quit as those who used placebo, with no significant adverse events. Clearly, 5.3% sustained abstinence at 12 months is a low number. But remember, this is a population who are identified as unwilling or unable to quit. And that low number is twice the number of those who took placebo. So it may well be that we should be taking everybody who is telling us that they're not ready and saying, you can actually just put a patch on with no investment of hope or intent of cessation and just see what happens. Now that might be a stretch. I'm kind of exaggerating the point to make the argument that NRT, which comes with very little or no risk, could be used just simply to encourage our patients to examine their motivation around cessation. And in this population, you can see they'll be twice as likely to quit at the end of the year compared to those who receive placebo. Okay, so what about varenicline in this reduce to quit paradigm as well? And this is now part of the label in the United States. because of this study primarily. This study that was published in JAMA looked at 1,500 participants, again defined as unwilling or unable to make an abrupt quit attempt. And these individuals were given either 24 weeks of varenicline or placebo, and their reduction targets were 50% reduction by 4 weeks, 75% reduction by 8 weeks, and then a quit attempt at or before 12 weeks. And then when you look at the continuous abstinence numbers for these individuals, those who received the 24 weeks of varenicline, 32.1%, were abstinent between weeks 15 and week 24. And those who received placebo, 6.9%, were abstinent between weeks 15 and weeks 24. So a relative risk for cessation of over 4 in these individuals who were unwilling or unable to quit. And so quite reasonably, their conclusion was varenicline offers a treatment option for smokers whose needs are not addressed by guidelines that recommend abrupt cessation. And we now have this as part of the American label, literally as a couple of months ago. Jumping into NRT and Varenicline combinations, these traditionally have not been recommended for two reasons really. One, due to the risk of adverse events and unproven benefit, but also because in terms of the concept of the way that varenicline works by blocking the nicotine receptor, it seems somewhat illogical to therefore then combine nicotine replacement with NRT. But as I said earlier in the presentation, many prescribers, many specialist cessation settings have been adding short-acting NRT to varenicline. So for those individuals who almost eliminate their tobacco use, it seemed to make sense to give them some gum to use with their varenicline, for example. Even though there was a lack of evidence to support that practice, I think it's become reasonably commonplace. But now there are numerous studies, actually 4 that I'm aware of, that are starting to look at varenicline and nicotine patch combination. And the biggest study and the most well-designed is this South African study that was published in JAMA a couple of years ago that looked at the efficacy of varenicline and patch versus varenicline alone. And in this study, reasonably decently sized, over 400 patients, multi-center, randomized controlled trial, and patients were randomized, as I said, to 12 weeks of treatment with 12 weeks of follow-up with either varenicline plus patch or varenicline alone. And when you look at continuous abstinence rates between weeks 9 and 12, so on the last 3 weeks of treatment, for varenicline plus patch, 55.4% were abstinent, and for varenicline alone, 40.9% were abstinent. So an odds ratio of 1.85, and this was statistically significantly different. So their conclusion, again, reasonably, I think, the authors of this study concluding varenicline and varenicline NRT patch combination is more effective than varenicline alone, and importantly, there was no difference in adverse events. And I think this is a practice that we're going to start seeing more and more. We certainly have used it in our clinical setting, but one of the big obstacles, of course, and I'm sure everybody is thinking about this already, is cost. In British Columbia, we have 12 weeks of coverage for NRT for everybody in the province. We have 12 weeks of coverage for varenicline under specific circumstances. But when you start doubling up on medications, there is no mechanism, save some health authority programs which are able to access funding for these kinds of approaches. But largely, there is no mechanism to cover the cost of these kinds of approaches other than patient self-funding, which most of us know, which we know for most patients is not very realistic. Okay, and then getting on to electronic cigarettes or electronic nicotine delivery systems. We could spend, of course, many hours talking about the pros, the cons, the studies that are for and against, and discussing the whole debate and the different positions that various individuals are taking around electronic cigarettes. We won't do that, but I'll try and summarize the real lack of consensus and the real difficulties that I think folks in tobacco control are having with the electronic cigarette debate by showing you these two statements. These two statements were released within a couple of days of each other last year. The first one is from the American government, or an agency of the American government, and the second one is from Public Health England, which is an agency of the UK government. And you can see that they are really anything but consistent. In fact, you could argue that they're about as diametrically opposite as they could be. The first one concludes that the current evidence is insufficient to recommend electronic cigarettes for tobacco cessation, recommends that clinicians direct patients who smoke tobacco to other cessation interventions with established effectiveness and safety. And the UK folks say estimates show e-cigarettes are 95% less harmful than normal cigarettes, and when supported by a smoking cessation service, help most smokers to quit tobacco altogether. Very different statements. Like I say, as much as I'm tempted, I won't get into being critical of either of these positions, other than to say that 95% number has been highly criticized. It was essentially the opinion of a committee of so-called experts, two of which had ties to the electronic cigarette industry. So it's not really an evidence-based statement. But there you are. Those two statements are out there. Many people have jumped on those statements to support their arguments on one side or the other. I'm just going to comment on e-cigarettes, as I said at the beginning, entirely on from the perspective of using these products for resistant patients or non-responders. And we know that our patients are coming to our clinical settings and saying, hey, what do you think about me using this product? I've used patches before, I've used Varenicline before, I'm still smoking, I've not been successful, and my buddies recommended this device to me, and out it comes from the pocket, and you are presented with a third generation, very impressive looking electronic nicotine delivery system, and you are put in the position of making comment on whether you think this is a good idea or a bad idea. I think that's a reality for many of us. And I think what we should be saying at this time should be words to the effect of, look, it may well be the case that this is a much safer option than the use of combustible tobacco. Conceptually, we believe that the vapor is less harmful than the smoke that is created by burning tobacco. So you may well reduce your personal risk by switching entirely to the electronic nicotine delivery system. But I think we have to caution that statement or qualify that statement by saying that at this time, we don't know by how much you will reduce your risk. And actually, in terms of long-term use, we really don't know because we don't have long-term evidence. And we also, I think, need to comment on the fact that because these products are essentially unregulated, and because there are many hundreds, maybe even thousands of these products on the market, it's very difficult for us to comment on the specific safety of any one given product compared to another. So to wrap that all up, what do we actually say to our patients? I think what we say is that your personal risk may well be reduced by shifting to to vaping compared to using using orthodox tobacco cigarettes, but we do have some concerns. And I think we should be directing our patients back towards the first line treatments. And I think what we should be saying is that it may well be that these products have failed you in the past because they've not been used to the best of their ability. You may not have had them at higher doses, you may not have had them in combination, and some of those approaches might actually benefit you. We would recommend that you use those products maybe in that way rather than the vaping device that you have in your hand. But of course, our patients don't always listen to us. Many of our patients will vape, and I think we have to work with them in the way that we would work with our patients around any other behavior about which we have some degree of concern. So that, I think, is my final comment. I think ending with electronic cigarettes is probably the best place to end. I've already made these statements, but I think these kinds of off-label approaches are becoming more widespread practice in smoking cessation settings. The titration principles do appear to be beneficial for some highly dependent patients, though that's not always very well reflected in published research. And labels are beginning to change around the world, and it's gratifying that they are, because for those of us who've been doing these things are outside of the label, it's nice to see the label shift in our direction, and for it to be easier for us to defend our practice. So I will stop there. Maybe I'll take a little look at some of the questions and invite more. So Karen Taylor has asked a question. Has the FDA finalized the label changes? For example, wording about smoking cigarettes, then using NRT and continuing to smoke. Other countries adopting the FDA label changes. So yes, the labels have changed in the United States, and I think I flashed up a part of the label from nicotine gum in one of my earlier slides, in which it said two things. If you relapse to smoking, don't discontinue your NRT, which of course is therefore allowing the concurrent use of cigarettes and NRT. And it also made the comment about extending duration of treatment. So those label changes, I believe, are in place in the United States. And we've seen some of those label changes occur in this country from the beginning of the year. There's a comment about in Saskatchewan, NRT is not covered on the formulary, but Varenicline and bupropion are. Yeah, I'm certainly aware that we have differing levels of coverage for smoking cessation medications around the country. I think here in BC we have possibly the best, in that we do cover all of the products. But we continue to advocate for more of these off-label approaches to be covered for, certainly for some of the more hard-to-treat populations. Okay, so there's a question from Marilyn White Campbell. I'm wondering about geriatric considerations and risks for patients who have chronic depression. Okay, so maybe I'll take the second part of that question first. The risks for patients who have chronic depression. And it's a very good question, and I suspect that you are raising the question of the safety of both varenicline and bupropion in the context of patients with depression, and the fact that we have warnings on the label for both of those products, actually boxed warnings that advise us to be cautious around the emergence of neuropsychiatric side effects, and to continue to monitor for patients who take those medications, and to discontinue if there is in fact the emergence of neuropsychiatric adverse effects. I didn't put it into this presentation, but for those of you who haven't seen the EAGLE study, which was published in April of this year in the Lancet, and if you're involved in smoking cessation practice, then you absolutely need to be familiar with that study. It's the biggest smoking cessation study ever, and it really is groundbreaking, and it should arguably bring to an end this concern about smoking cessation medications and neuropsychiatric side effects. In a nutshell, this 8,000 subject study, which had two cohorts, so those 8,000 patients were split into 4,000 patients with a history of psychiatric illness, so stably treated psychiatric illness, and 4,000 patients without psychiatric illness. And in both those cohorts, those 4,000 patients were split into four, 1,000 each receiving NRT, bupropion, varenicline, or placebo. And the headline from that study is that in both the psychiatric cohort and the non-psychiatric cohort, there is no difference in neuropsychiatric adverse events when you compare varenicline, bupropion, NRT patch, and placebo. So there is no difference between varenicline and bupropion and placebo in this massive study, half of which the subjects are those with psychiatric illness. So we can treat patients with depression with varenicline. There really is no reason to disqualify those patients. Having said that, we still have the label that it has a boxed warning. So I think as prescribers, we do need to exercise some caution. But certainly I would encourage you all to take a look at EAGLES because it's an important study. And I can see that there are promises to send out the link to the study, so that's a good thing. So last 3 minutes, if you have a question. Oh, I do see one that I missed there. I think. Oh, geriatric dosing. Geriatric dosing is done in a bit of a vacuum of evidence. I'm not really aware of any specific evidence in treating the elderly. I would suggest that we do standard dosing unless there's a reason to believe that we should be doing differently. If somebody is frail or is underweight, we may well reduce dosing. Of course, with varenicline, if there is impaired renal function, we would reduce dosing. But that's not evidence-based. That's just the kind of caution that we would exercise if there are any specific clinical factors. Oh, there's a question about pregnancy and NRT use in the last minute here. Many of you will be familiar with the use of NRT in pregnancy. It is, of course, off-label. The NRT use is not recommended in pregnancy, but the approach of most specialist tobacco treatment settings is that if behavioral counseling is not effective in promoting cessation in a pregnant woman who smokes, then we should consider using NRT off-label because it will be preferable conceptually to have the delivery of clean nicotine versus nicotine and thousands of chemicals. We do have some reasons to be concerned about nicotine in pregnancy. There are animal studies that suggest that nicotine is neurotoxic to the fetus. So that would be why we would use behavioral counseling preferentially. But I think most people accept that if there is ongoing smoking, it would be preferable to have the use of NRT. We may try and minimize the exposure of the fetus to nicotine by using short-acting nicotine replacement therapy such as gum or lozenge. But it would be off-label. We would need to do informed consent and to really sort of have that risk-benefit discussion with the patient. Okay, so at 9:59, one last question maybe, if anybody has anything burning. Otherwise, maybe we get ready to close up here. So I'll hand over to the folks at CAMH Mission Control there, and maybe we'll close it down.
Hello everyone.
Thank you.
So I see that there are a couple of questions regarding viewing the presentation later. Yes, not to worry, we do record all of our webinars, and the link will be sent out. So just a reminder that the link to the evaluation and post-learning assessment will be emailed to you today, and you have 1 week to complete this in order to receive your letter of completion. If you need to email me because you participated as a group, please be sure to do so by end of day today, preferably by 2 p.m. My email address is on the screen. As well, the next session will be on November 23rd. The topic is Tobacco Cessation Efforts in Cancer Care Settings, Lessons Learned in Program Implementation, and it'll be presented by Dr. Meredith Giuliani from Princess Margaret Hospital. And Teach Educational Rounds, as I mentioned, are recorded and they can be accessed by clicking the link on the screen, and they'll be listed there by date. So thank you everyone for attending, and we'll see you next time. Oh, and thank you, Dr. Khara, for a great presentation.
And we'll see you next time. Oh, and thank you, Dr. Khara, for a great presentation.